So today let us learn about biliary anatomy and pancreas and its variants. So first of all, biliary anatomy, we will study about the embryology first. So that is from the foregut uh, arises the ventral pancreatic. From the foregut arises the hepatic bud in the ventral wall towards the growing into the ventral mesogastrium. Growing into the ventral mesogastrium towards the septum transversum, that is hepatic bud, and it is later divided into two, that is pars hepatica and pars cystica. So pars hepatica is growing towards the septum transversum through the ventral mesogastrium. So this from the foregut hepatic bud is arising in the anterior in the ventral wall, arising the hepatic bud is arising in the ventral wall, and it is divided into pars hepatica and pars cystica. Pars hepatica is growing uh, through the ventral mesogastrium towards the septum transversum, and it will later form the right and left lobe of liver and also the right and left hepatic ducts, whereas pars cystica will develop into gallbladder and the cystic duct. So this is the anatomy: gallbladder, cystic duct. Gallbladder itself has got the fundus, body and neck of gallbladder, then cystic duct, and here it is right and left hepatic ducts. They form common hepatic duct. Common hepatic duct with cystic duct form common bile duct. They join with pancreatic duct and bulla of Vater, the second part of duodenum. So this is the parts of gallbladder: fundus, body and neck of gallbladder, and at the junction of this neck and the cystic duct there could be an outpouching called Hartmann's pouch, where the gallstones can lodge. That is Hartmann's pouch. And the mucosal folds inside the cystic duct, that is spiral valve of Hister. So we know right hepatic duct and left hepatic duct form the common hepatic duct. So right hepatic duct itself is divided into right anterior segmental duct and right posterior segmental duct. So the right posterior segmental duct and right anterior segmental duct. Right posterior segmental duct is draining from the 6 and 7. Right anterior segmental duct is draining from 5 and 8. So, and like that in left hepatic ducts, there is left hepatic duct. It is draining from 2, 3 and 4 segments. From the caudate lobe, it can drain either into the left hepatic duct or the right hepatic duct. So here the variant that can occur in this ducts are, so here right posterior segmental duct. So right anterior segmental duct, it is arising from the right hepatic duct. It can arise from the confluence at the junction of the right hepatic duct and left hepatic duct, that is trifurcation, that is type 2. Type 3A is most common, where the right anterior segmental duct is arising from the left hepatic duct. It can arise from the common hepatic duct, that is type 3B, and type 4 it is arising from the cystic duct. Significance is when there is planning for a segmentectomy For example, left lobe of liver in case of liver transplant donor. In that case, ligating this left hepatic duct injures this right posterior segmental duct, leading to bile leak. This is the most common variant, type 2A, where right posterior duct is draining into the left hepatic duct. Here other variants that can occur is gallbladder agenesis, duplication, septation, and cystic duct variant. Cystic duct can have a right lateral insertion. It can insert spirally and anteriorly, posteriorly. It can have a common sheath with the common hepatic duct. It can have a very proximal insertion and also distal insertion, that is at the distal 1/3. So the significance is we are planning for cholecystectomy. In some cases it can injure, since like when we told this common sheath with hepatic duct, it can injure the common hepatic duct. Now choledochal cysts, they are the aneurysmal dilatations of the biliary tree, and this can predispose to cholangiocarcinoma. So type 1 is when there is a cystic dilatation, could be cystic saccular or fusiform dilatation. Type 2 is a diverticulum. Type 3 is choledococele. Type 4A is intrahepatic and extrahepatic. Type 4B is extrahepatic and type 5 is intrahepatic. Pancreas anatomy, it is extending from the second part of duodenum and it is running obliquely towards the splenic hilum. So it has got uncinate process, head, neck, body and tail. Uncinate process, it is the posterior and medial extension from the head, and it is between the IVC, inferior vena cava, and superior mesenteric vein. And then comes the head. So head is located within the C shape of the second part of duodenum. Behind the neck is the portal confluence. Splenic vein and superior mesenteric vein joins to form the portal vein. Then comes the body. So behind the body is the aorta and superior mesenteric artery, and also behind the posterior surface, along the posterior surface of the body runs the splenic vein. Splenic artery is running at the superior border of the pancreas, and the tail is towards the anterior pararenal space. It is ending at the splenic hilum. So this is the anatomy. Head, you can see uncinate process between IVC and superior mesenteric vein. And then comes the head. So head is in the C shape of the second part of duodenum. Behind the neck is the portal confluence, splenic vein joining with superior mesenteric vein to form portal vein. Along the posterior border of the body runs the splenic vein. Tail is towards the anterior pararenal space, that is ending at the splenic hilum. Regarding the blood supply of the pancreas, so the main blood supply is from the three arteries. One is directly from the celiac trunk. If you are saying splenic artery, it is supplying the body and tail, and then splenic artery is giving common hepatic, out of which hepatic and gastroduodenal. So gastroduodenal is supplying the neck and body. Then that is the two branches from celiac trunk itself. Then superior mesenteric artery is supplying the inferior part of the head. Embryology, the development of pancreas is, as we told in case of liver, from the foregut arises the, we told hepatic bud, like that here in case dorsal pancreatic bud and ventral pancreatic bud. Dorsal pancreatic bud and ventral pancreatic bud. So that is later what happens is there will be, due to the differential growth, due to the rotation of the intestine, this will become to the right. Ventral pancreatic bud will be to the right and dorsal pancreatic bud will be to the left. Now there will be rotation due to the differential growth of duodenum, that is the dorsal pancreatic bud will rotate and they come towards the left itself below the dorsal pancreatic bud, that is rotation, and later the fusion of these two pancreatic buds. So the ventral pancreatic bud is giving rise to the inferior part of the head and the uncinate process, whereas superior part of the head, neck, body and tail is formed by the dorsal pancreatic duct. Then similar way the duct also, that is the dorsal duct and the ventral duct will be there, and later they will come in, either another duct will be there communicating between the two. So that the main duct is, that is duct of Wirsung. It is formed by the ventral pancreatic duct and the distal part of the dorsal pancreatic duct. Then what happens to the proximal part of the dorsal pancreatic duct? That will become the accessory pancreatic duct or duct of Santorini, and it is opening into minor duodenal papillae, and the major duct or duct of Wirsung is opening into major duodenal papillae. This is normal. Normal is this, in 60% of people what happens, the drainage, majority of drainage is by this duct of Wirsung, but some secretions can drain to the minor duodenal papillae. Some secretions from the head can be drained by this accessory pancreatic duct in 60% of people. In 30% of people what happens, the regression, this accessory duct will regress, involute. What happens in the 10% of people, they will be having something called pancreatic divisum, that is two duct will be opening separately. We will discuss that. So next is pancreatic protocol. What are the indications why we are taking, that is in case of some tumors in pancreatitis, when we are expecting some complications in pancreatic diseases or pancreatic interventions like CT guided biopsy and drainage. So pancreatic protocol, the tracking begins, the region of interest is abdominal aorta when the enhancement is more than 100 Hounsfield unit, that is around 10 to 12 seconds post trigger in the late arterial phase. So the main phase, two phases we are taking, we will take non-contrast phases in order to determine the calcification or hemorrhage, and the other two phases we are taking is late arterial, that is pancreatic phase, pancreatic parenchymal phase and portal venous phase. Pancreatic parenchymal phase is 35 to 40 seconds post injection, and portal venous phase is 60 to 70 seconds post injection. So the scan coverage is from the diaphragm to the iliac crest. In portal venous phase, it can be from diaphragm to pubic symphysis. Now the congenital variants, there can be variants in the ductal anatomy, variants in the pancreatic anatomy. So in the ductal anatomy, it could be variation in the course, variation in the ductal configuration, pancreas divisum, Wirsungocele, Santorinocele, anomalous pancreatico-biliary junction. The variations in the parenchymal anatomy, it could be annular pancreas, circumportal pancreas, dorsal agenesis, ectopic pancreas, then intrapancreatic splenic tissue, congenital pancreatic cyst. So the variations in course, this is regarding the main pancreatic duct. Either it can travel descending, it can travel vertical, or it can have a sigmoid curve, it can loop. Variations in this accessory duct is joining. It is a slender, narrow connection of the main pancreatic duct with the duodenum at the minor papilla, that is accessory duct. So it can maintain the connection with the, anatomically it can be there, but functionally it may not be draining, not draining into duodenum. Here the connection with the minor duodenal papilla is lost. Here there is no communication with the main pancreatic duct. Sometimes it can have a sigmoid curve and enter into the duodenal papillae, that is ansa pancreatica. So this is pancreas divisum. Pancreas divisum, as we have already told, in 60% of the population what happens is the two ducts will be there. Majority of secretion is by this duct of Wirsung or ventral pancreatic duct, and some secretions can be drained by the dorsal pancreatic duct. in 30% of people, the dorsal pancreatic duct, the accessory duct will regress, which is not functional. Anatomically also it can regress. In later 10% of people, the two ducts, the communication duct is lost. There is no communication duct. That is, congenitally they are having only two separate ducts. That is classical pancreas divisum, where there is no fusion of this ventral and dorsal duct. So what happens? Here in this case, dorsal duct will be the major duct. In normal people, it is the ventral duct, but in these people's, it will be the dorsal pancreatic duct. The majority of the secretions will be draining, and the ventral pancreatic duct will be draining from the lower part of the head and uncinate process along with the common bile duct. That is type 1, which is classical pancreas divisum, and in type 2 it is the ventral duct will be absent. So the only secretion is by the dorsal pancreatic duct. In the major duodenal papillae, only the secretion is from the common bile duct. Now in type 3, it is there anatomically, there is a rudimentary communication, but it is not functional. Usually what is getting regressed is dorsal pancreatic duct, but in this case it is ventral pancreatic duct getting regressed. So we can see that there is communication channel also, but it is rudimentary, it is not functional. So in case of MRCP, we can see that the main pancreatic duct, it is crossing the CBD. Here we can see the ventral pancreatic duct and dorsal pancreatic duct separately. Here we cannot see the ventral pancreatic duct. Here we can see the communicating duct also in the MRCP images. Now ansa pancreatica, we have already told, that is the accessory duct. Instead of joining straight to the minor duodenal papilla, it is having a sigmoid curve. The importance is that there can be pooling of secretions, and it is trigger for pancreatitis. Santorinocele and Versenocele. So Santorinocele means at the duct of Santorini, that is the ventral dorsal pancreatic duct. At the joining to the minor duodenal papillae, there is a cystic dilatation, and Versenocele means cystic dilatation at the end of the major, that is ventral pancreatic duct. So in this image we can see this is Santorinocele. It is associated with the pancreatic division. It is crossing the bile duct. So there is pancreas divisum, and associated with this at the terminal end there is cystic dilatation. So this is Santorinocele. Anomalous pancreatico-biliary junction. Usually what happens is the main pancreatic duct and CBD is opening together into the major duodenal papillae at the ampulla of Vater. But here they are joining and having a common channel and opening into this duodenum. So this common channel can, if it is more than 15 mm, that is anomalous pancreatico-biliary junction. What happens then? There will be reflux of secretions, vice versa. So the biliary secretions can reflux into pancreas, causing pancreatitis. Pancreatic secretions can go back also, and usually associated with this people can have choledochal cyst also, predisposing to cholangiocarcinoma. The classification of ABPJ is Comey classification, and type 1 is they are perpendicularly joining. Then type 2 at an acute angle. Type 3, apart from this, there is some other duct complicating, that is type 3. Then annular pancreas means we already know the formation, and initially there will then rotation and then fusion. But in annular pancreas, so we already told the problem with the rotation, problem with the fusion, that is pancreas divisum. This is problem with the rotation. Here there is adhesion of the ventral pancreatic tissue to the duodenum, so that it is not completely rotated to fuse with the dorsal pancreatic, but that is it is in partly or completely encircling the duodenum. So it could be partial or complete annular pancreas, and the significance is this can be occurring along with some symptoms like Down syndrome, Hirschsprung's disease, and polysplenia. Then complication is it can cause duodenal obstruction. So this is image of the complete annular pancreas. Here in this image is taken after oral contrast. That's why we can see the duodenum enhancement. And this image is after IV contrast. We can see the pancreatic tissue around the duodenum is enhanced. Now this image we can see the ventral pancreatic duct is having this is ERCP image. Ventral pancreatic duct is having a circular course. That means it is annular pancreas. Now this is a barium study showing narrowing of lumen of the duodenum. That means there is obstruction. This is a partial annular pancreas where the duodenum is not completely encircled, only partially encircled by the pancreatic tissue, and it resembles a crocodile jaw appearance. Now instead of surrounding the duodenum, it could surround the portal vein or superior mesenteric vein, which is portal annular pancreas or circumportal pancreas. So here we can see the enhanced pancreatic tissues around the portal vein. Now this is also got some divisions, that is whether the splenic vein is running below or splenic vein is running above this or through this pancreatic tissue. And also another division is based on the position of the main pancreatic duct, whether it is running anterior to it or posterior to it or both. Then arterial annular pancreas is so as we told, pancreatic tissue can surround the duodenum, it can surround the portal vein. Very rarely it can surround some artery, usually anomalous right hepatic artery. Now ectopic pancreas means the pancreatic tissue is outside, located somewhere without any, there is no vascular connection or anatomical connection with the inherent pancreatic tissue. That is ectopic pancreas. But whatever whatever changes that can occur in the normal pancreatic tissue can undergo in this pancreatic tissue as well. So mostly it can be in the stomach, it could be in the intestine. So it could mimic a submucosal mass and it may cause gastric outlet obstruction. So in this image here in the stomach there is some enhanced pancreatic tissue located. In this image also there is some tissue located at the antrum of the stomach and with some distension of the stomach, causing some distension of the stomach. Now this is another one, intrapancreatic accessory spleen. This is another variant. Then bifid pancreatic tail means that pancreatic tissue itself is dividing into two like fish tail appearance, along with the duct also. Duct is also dividing into two, and in this case the telltale sign of this bifid pancreas is the tail will never reach the splenic hilum in this case. So this is the images, MRCP images showing bifid, the two ducts, and this is the ERCP image showing the duct division. Then agenesis of dorsal pancreas means it could be partially or completely. The dorsal pancreatic tissue, it can be absent. So as a result there can be compensatory hypertrophy of the rest of the pancreas. And in this people there can be hyperglycemia because beta cells are mostly located in the dorsal pancreatic tissue. So it can lead to hyperglycemia in these people. So in dorsal, when there is complete absence, the dorsal pancreatic duct is also absent. Along with the dorsal pancreatic tissue, the dorsal pancreatic duct and the minor duodenal papilla, everything is absent. Only they have is ventral pancreatic tissue, ventral pancreatic duct opening into major duodenal papillae. But in partial, there can be duct can be present, that some part of the tissue can be absent. So this image, what happens is there is uncinate process head, neck, but part of the body and tail is absent. Instead, that area we can see the bowel loops. So that is called a dependent intestine sign. Dependent intestine sign. So if there is pancreatic tissue, it will not reach it will not be abutting the splenic vein. But since the pancreatic tissue is not there, it is abutting the splenic vein. Now this is how in agenesis of dorsal pancreas, what if there is fat, that is pancreatic lipomatosis, the presence of fat between the two, it will also prevent the bowel abutting the splenic vein. So in this image, we can see there is no body and tail. We could not see the body and tail in this first image. And we can see the bowel is abutting the splenic vein. So it is dorsal agenesis, that is positive dependent viscera sign. But in the second image, we could not see the body and tail, but the bowel is not abutting. So that is pancreatic lipomatosis absent dependent viscera sign. Congenital pancreatic cyst is another variant. It could be solitary or it could be multiple, and the syndromes associated with cystic conditions like von Hippel-Lindau disease and autosomal dominant polycystic kidney disease.